Hello and welcome everyone to today's PPHA guest webinar. We're really excited for this one. Today we're going to be hearing from Janet Barge, Allison Adams, and Merhawi Gabreski about the statewide health assessment of Pennsylvania. This meeting will be recorded and will be posted on the PPHA YouTube channel afterwards, so don't worry about if you have to miss any of it. And we're also going to be leaving some time for Q&A at the end of the presentation. So please post any questions you have in the chat and we'll get to them at the end. And now I'll pass it over to our speakers. So excited to hear from you guys.
Okay, good morning, good afternoon, everybody. And thank you, Brooke, for coordinating this today. My name is Janet Barge. I work at the Pennsylvania Department of Health in the Office of Operational Excellence and worked with PHMC from our office to develop this state health assessment. We're excited to share it with you today. So what we're going to cover is what is a state health assessment and how can it be used. Allison's going to talk about the process that was used to develop it and the design of the assessment. And then Merhawi will speak to you about some of the findings in the report itself. So the purpose of a state health assessment is to describe the population. Can you go to the next slide, Allison? And the populations most impacted by particular health issues. We identify factors that contribute to particular populations being most impacted and identify areas that can, this will identify areas for health improvement. The report also includes community assets and resources that can be used together to improve population health. It's the basis for a lot of opportunities. We hope that both the public, policy leaders, the Department of Health, and other agencies can use it for setting priorities, planning, program development, using it for when they're writing grant applications or funding applications, addressing issues that need to be addressed through policy changes, coordinating and collaborating to form broad partnerships to improve health. Our next step in the department and in my office is to develop a state health improvement plan. So the assessment talks about what are the health issues, and then the state health improvement plan is the strategic plan. It will be a 5-year plan, and it will be to take those priority health issues and develop strategies to address them. So we're planning to develop it over the next year from approximately June this year till March next year. And as I said, we'll be using it to develop priorities, evidence-based strategies. We'll have SMART measures, which are measurable and then can show the impacts of the strategies. And since it's a 5-year plan, we'll break it down into annual plans for implementation. And we encourage broad participation in this. So not only from Department of Health staff, but from other agencies and from community across the state, community people across the state. We have an organization called the Healthy Pennsylvania Partnership, which we work with to develop our state health assessment and the state health improvement plan. The partnership has something like 280 participants right now, and it's open to new members, and can be people in healthcare, in non-healthcare related organizations. We include just the public, people in community organizations, people in transportation or education, lots of different sectors impact health. We have this broken into an executive committee that helps put forward plans and processes for how we will implement the work. And the main work in the Healthy Pennsylvania Partnership are these two projects, the State Health Assessment and the State Health Improvement Plan. And we have a State Health Improvement Plan right now that's going to be ending over the next year. And it's working on the priorities in it are primary care and preventive services, obesity, physical inactivity and nutrition, and mental health and substance use. Those were the priorities selected about 5 years ago when that plan was developed. And the new plan could address the same, or they could select new priorities in the coming 5 years. And in the state health assessment, we have work groups that will keep the assessment current. And these work groups are broken into social determinants of health, access to care, maternal and infant health, chronic and infectious diseases is in the second one, substance use and mental health is in the third work group, and environmental health and injury and violence is in the fourth work group. So you're welcome to reach out and let us know if you'd like to participate in any of the work of the Healthy Pennsylvania Partnership.
Hi, everyone.
And I'm going to turn this over to you, Allison, now.
Wonderful. Thank you very much, Janet. Hi, everyone. My name is Allison Adams, and I am a research coordinator at the Research and Evaluation Group at Public Health Management Corporation. This afternoon, I will be speaking on behalf of the project group who authored the state health assessment and managed all of the meetings, data collection, and data analysis for this report. The project group consisted of Pennsylvania Department of Health staff, Public Health Management Corporation project staff, and Bloom planning advisors, all of whom you can see listed in the report if you'd like to know who exactly was working on this. Oh, my slides are sticky. One second. There we go. Can everybody still see the screen?
Yes.
Okay, wonderful. Thank you. This overview shows the main phases of the state health assessment process. The planning phase of the state health assessment, or SHA, began in March of 2020, which led to our first stakeholder meeting in April of 2020. Stakeholders from the Healthy Pennsylvania Partnership were informed of the mission, vision, and guiding principles for the partnership, and were also provided with an overview of background literature and potential report visuals. Between the first and second stakeholder meetings, stakeholders participated in a stakeholder assessment and 8 focus groups to select and contextualize key health themes and issues that should be highlighted within the report. Key health indicators were further refined between May and July of 2020 at the second and third stakeholder meetings, which coincided with the drafting phase of the report. The draft of the report was completed in October of 2020 and was distributed to a panel of experts for initial review. Following the experts' review, the report draft was submitted to the public for review in November of 2020, and final comments were addressed by the conclusion of December. The final SHA was approved and published in January of this year. We used a variety of tools and methods to gather information about health in Pennsylvania. We began our process with a literature review of 14 state and local health assessments to build our indicator database of potential health topics and data points to highlight within the report. We then conducted an assessment with stakeholders from the Healthy Pennsylvania Partnership to better understand and identify the key health issues within our broad themes, as well as priority populations, important criteria for selecting health indicators, and local and statewide assets. In total, 77 stakeholders participated in this assessment. We then held 8 focus groups with 67 stakeholder participants in May and April of 2020, one for each of the health themes we identified for the report. Each focus group gathered input on challenges and barriers experienced by communities across the state related to the theme at hand, resources and assets within communities, and implications of social determinants of health. To supplement our stakeholder engagement, a public poll was also conducted to understand the greatest health needs of Pennsylvania residents and further inform the priority health issues for the Shaw Report. A total of 2,000 individuals from 66 of Pennsylvania's 67 counties participated, with age, sex, race, and ethnicity of participants balanced to reflect the demographics of the state. From our literature review of other state health assessments and local community health assessments, we identified 8 topic areas as being the most commonly explored themes. Upon further discussion with stakeholders, we moved forward in considering these themes to be core components of health in Pennsylvania. The stakeholder assessment meetings and focus groups allowed us to identify the scope of each theme and select key health indicators. Each theme is represented by a set of health issues. Health issues were further represented by specific data points or indicators. At the start of the process, a total of 47 priority health issues were identified across themes, with approximately 1,073 accompanying health indicators. We employed a rigorous set of criteria for filtering indicators to ensure that they were most reflective or most important to explore for health within Pennsylvania. These indicators were scored by 2 independent topic experts across these criteria, which included whether the indicator was a Healthy People 2020 Leading Health Indicator, which indicated that the data were selected as high priority health issues for the nation. Indicators were also selected if they impacted multiple health issues, were severe and high in magnitude, were directly comparable to other states or countries of interest, had trend data available, or could be broken into subgroups of interest. The main themes selected for the report were access to care, environmental health, mental health, maternal and infant health, substance use, injury and violence prevention, chronic diseases, infectious diseases and immunizations, and social determinants of health and health equity. I will now start going into the section discussing the health themes. Starting with an overview of the current demographics of Pennsylvania residents. About 1/4 of Pennsylvanians were under the age of 20 and 1/3 were 55 and older. In 2019, Pennsylvania had a larger proportion of its population aged 65 and older than the US overall. And Pennsylvania's older population grew between 2010 and 2019. This age groups 65 to 69 and 70 to 74 grew by 34% and 43% respectively. 2019 census data show that 1 in 5 Pennsylvania residents identified as Black, Asian, multiracial, or other. 8% identified as Hispanic or Latinx. And between 2010 and 2019, Pennsylvania's population increased by about 0.8%. During that time frame, the population of white residents showed minor growth, while Asian or Pacific Islander and Hispanic populations each increased by about 39%. The report also highlights the leading causes of death in Pennsylvania. At the top of the list for 2018 were heart disease and lung cancer across all residents. However, leading causes of death differed by age group. For those 20 to 44, the leading cause of death was accidents. For those 45 to 74, the leading cause of death was cancer. And for those over the age of 75, the leading cause of death was heart disease. The full impact of the 2019 novel coronavirus, or COVID-19, has yet to be seen. To date, COVID-19 has led to the deaths of 25,688 Pennsylvanians and has a high mortality rate of about 201 deaths per 100,000 people. Rates of current cases are especially high in the southeastern region of Pennsylvania. Health disparities persist throughout Pennsylvania, and residents across the state die prematurely and live with poor quality of life due to social, economic, and service environment and physical environment factors. These social determinants of health are discussed throughout the report to further contextualize the health issues residents face, including education, socioeconomic status, social supports, access to services, systemic racism and oppression, racial segregation, housing, and built environment. A few examples of disparities found throughout the report include how Black and Latinx households were 3 times as likely to live in poverty as white households. About 1.4 million people struggled with hunger in 2018. About 13% of residents spent half or more of their household income on housing, and 13,199 people experienced homelessness on any given day in 2019, 52% of whom were Black. Additionally, 69% of housing units were owner occupied, 4% of adults were unemployed in 2019, 28% of households earned less than $35,000, and 16% of families with children lived below poverty. The most recent data for these social determinants of health were gathered from the 2019 American Community Survey, the 2019 Feeding America Report, the 2019 Annual Homelessness Assessment Report, the 2018 Behavioral Risk Factor Surveillance System data, and the 2019 Adverse Childhood Experiences in Pennsylvania report. I'm now going to pass it over to Merhawi to present the findings from each theme.
Thank you, Alison. My name is Merhawi Gebreski. I am epidemiologist working in the Office of Operational Excellence, the Department of Health. So as Alison mentioned, there were 8 themes or health topics, and there was an overarching theme, which is social determinants of health. So we selected some findings from each of these themes, and we are going to present this. But if you want details of this, it's recommended to visit the State Health Assessment document. I think Jen shared it in the chat box. So to start with access to care, we used different indicators to measure access to care, and we have 3 indicators here. One is having no personal health care provider. The second one is unable to see a doctor due to cost, and the third one is insurance. And as you can see, only 16% of our population had no personal health care provider. 10% were unable to see a doctor due to cost, and only 7% were, 93% were insured. That means 7% were not insured. And as you can see, there is also disparity by race and ethnicity. The red bar is for Blacks, and the green is for Hispanic. And as you can see, in each of those indicators, Black and Hispanic are disproportionately affected by this access to care indicators. Next slide. And there are several barriers to access to care, and we found that lower levels of education were associated with lower prevalence of seeking doctor's care. So education affects access to care. And we also looked at the healthcare professionals distribution across the state, and we found that there were fewer primary care doctors, dentists, mental health providers, and nurse practitioners in rural Pennsylvania compared to that of urban areas. And based on the 2020 LGBTQ survey, 1 in 3 of the respondents, the LGBTQ community respondents, feared of seeking healthcare service because of past or potential negative reactions from healthcare providers. So the barriers to different population is different. For example, for LGBTQ community, the barrier, one of the barriers is the views of healthcare professionals. We also look at access to broadband internet subscriptions because this affects access to care, and access to broadband internet subscription has increased from 81% in 2015 to 89% in 2019, but there is difference in which older adults and rural residents were less likely or have a lower rate of access to broadband internet subscription. Next slide. Thank you. And these are the indicators we use it to measure access to care across the state. I'm not going to go in detail of these indicators, but they were mostly from BRFSS, behavioral risk factor surveillance system, and from workforce survey. Next slide. And the next topic is substance use. And again, we use several indicators to measure substance use in the state. And in 2019, based on BRFSS survey, about 17% of adults being drunk, 10% used illicit drugs, and 7% has substance use disorder. And the LGB adults had higher prevalence of being drinking. So there is a disparity among populations in being drinking. Next slide. And the other indicator we use it to measure the situation of the substance use in our state is drug-induced deaths, which is a good proxy, and it's increasing in our state. In fact, based on America Health Ranking, Pennsylvania ranked 47 among the 50 states in drug-induced deaths, and Healthy People 2020 have a target for drug-induced deaths. It is 11.3 drug-induced deaths per 100,000 persons, but in Pennsylvania, it was 37 per 100,000 people, which is about 3 times compared to that of Healthy People 2020 target. And 65% of drug overdose deaths involved opioids. Next slide. And this is the distribution of age-adjusted drug-induced deaths across the state. And as you can see, the western part of the state and southeastern part of the state have higher rate of drug-induced deaths compared to the other counties. Next slide. And these are the indicators we use it to measure substance use in the state. Next slide. And the third topic is mental health. And we use it feeling hopeless or feeling sad to measure the mental health among high school students. And based on 2019 YRBS, that's Youth Risk Behavioral Survey data, high school students who felt sad or hopeless increased from 28% in 2015 to 35% in 2019. And this was higher among Hispanic and among LGBT high school students. The other topic we covered, coming back, thank you. The other topic we covered is suicide rates, and it increased from 12 per 100,000 residents in 2010 to 15 per 100,000 residents in 2018. And in 2019, 19% of Hispanic versus 13% of non-Hispanic white residents reported having 14 or more poor mental health days in the past month. This is based on BRFSS survey. Next slide. And as Alison mentioned, in addition to the quantitative data from different sources, we also used qualitative data to extract information. And the stakeholders discussed vulnerable populations who have reduced access to essential services and may have higher rate of mental health problems. This population include older adults, farmers, incarcerated people, residents in rural areas, institutionalized individuals, veterans, and LGBTQ plus individuals. Next slide. And these are the indicators for mental health. Next. And the other topic is chronic diseases. And as you have seen in the leading cause of this slide, chronic diseases are among the top leading cause of death in the United States as well as our state. And in 2018, the most common cause of death in our state was cardiovascular disease and cancer, and about 70,000 in that year of the 132,000 deaths, which is majority of the deaths were from cardiovascular disease and cancer. And about 47% of residents lived with one or more chronic diseases and with higher prevalence among those ages 65 and older. and rural counties were more impacted by chronic diseases. Next slide. Thank you. For cancer, based on 2015-2017 data, Pennsylvania, approximately in Pennsylvania, 1 in 2 residents will be diagnosed with cancer at some point during their lifetime, and 1 in 5 will die of cancer. And based on BRFSS 2019 survey, prevalence of smoking was higher among LGBT adults and among those with lower household income and lower educational status. Next. And we used lots of indicators to measure chronic disease in our state, and these are the list of indicators. Next slide. And the other health topic or theme is maternal and infant health. And we know that early and adequate prenatal care is important for health of the mother and the newborn. And we used different indicators to measure prenatal care. And one of the measures is a number of visits in the first trimester. And there is also another indicator to measure the overall antenatal care, and we used the no prenatal care measure here. And in 2018, 2% of females who gave birth did not receive prenatal care, and Black females were about 4 times as likely not to receive prenatal care compared to their white counterparts. And the other indicator we use it in maternal and infant health is neonatal abstinence syndrome. And in 2018, there were about 1,800 cases of neonatal abstinence syndrome, with highest rate among whites and among rural counties and among families with lower household income. Next slide. And stakeholders also identified populations that experience adverse birth outcomes. This population include rural and urban residents, low-income individuals, immigrants, undocumented individuals, those uninsured and underinsured, and populations lacking culturally appropriate service. Next slide. Thank you. And these are the indicators we use it to measure maternal and infant health in our state. Next. And the other topic is injury and violence. The good news is violent crime in Pennsylvania has decreased from 400 per 100,000 in 2008 to 306 per 100,000 in 2018. And between 2013 2018, the homicide rate held steady at 2 per 100,000 among white residents, but for Blacks, it was 29 per 100,000, which is about 14 times higher compared to the rate among white residents. Next slide. And we also included hate crimes and groups. The count of hate crimes increased from 38 to 67 between 2012 and 2008, and this is based on the FBI report. And most of the hate crimes were committed due to somebody's race, ethnicity, or ancestry, followed by religion and sexual orientation. And our state is among the top in hate groups, and it's in fact the 7th of the 50 states, and Washington, D.C. for its hate groups. This accounts for 4% of the nation's active hate groups. Next slide. And these are the indicators we use it for injury and violence. So disparities in each of these indicators is highlighted all across the report. Next. And environmental health is another section or health topic. And one of the major issues or public health challenges in Pennsylvania is air pollution, and our state ranked 47 of the 50 states for general public's exposure to acceptable levels of particulate matter, which is a measure for air pollution. And the state average exposure to particulate matter is 9.2 compared to that of the nation, which is 8.4. And we also looked at access to fluoride water, and residents with access to fluoride water the access to fluoride water was lower in our state compared to that of the nation, and only 56% in our state and 73% in the nation. And in 2019, 11% of Pennsylvanians were served by private wells. The problem with private wells is they are not monitored by EPA, and so they can pose hazards to the population. Next. And we also looked at lead levels among children, and in 2018, only 19% of children under age 6 were tested for lead levels, and among those tested, 4% had blood lead level greater than the recommended, which is 5 microgram per deciliter, and non-Hispanic Black and Hispanic children were more likely to have elevated blood lead levels. And children exposed to, of course, children exposed to secondhand smoke are at risk of adverse health outcomes. And in our state, based on 2017-2018 data, 19% of children lived with someone who smoked, and this is higher compared to that of the national average, which is 15%. Next slide. And these are the indicators used to access to assess environmental health in our state. Next slide. And we have the infectious disease and the immunization section. And one of the topics covered here is sexually transmitted infections. And between 2003 and 2018, syphilis has increased by 400%, chlamydia by 59%, gonorrhea by 34%. So there is increase in sexual transmitted infections, and Black and Hispanic individuals were more likely to be diagnosed with this sexually transmitted infections. Next slide. We also included information about COVID-19, and we included data until December or January. And of course, COVID-19 has highlighted the underlying disparities and long-standing health system gaps in our nation as a whole and even in our state. And still there is incompleteness in the race and ethnicity reporting of the COVID-19 cases. And as to now, only 65% of race is reported among the COVID cases, only 35% of ethnicity is reported. And among this, the impact is disproportionately higher among the minorities, and Black residents account for 12% of our population, but they account for 28% of cases and 21% of deaths. And Hispanic account for 8% of residents, but account for 26% of cases and 6% of deaths. Next slide. And these are the indicators for infectious diseases and immunization. And now I will turn over to the moderator for a Q&A session. Thank you.
Great, thank you. So I'd like to open it up to any questions that we might have from the audience. There aren't currently any questions posted in the chat. I can ask a question of my own, which is, is this an assessment that you plan to run annually, biannually, and how might you change or improve the assessment in the future?
I'll start with this, and Rahali, if you want to chime in too. We do plan to keep it current, and as I described, there's 4 work groups that are in place, and they've begun to hold meetings either monthly or every other month. And these work groups, which are part of the Healthy Pennsylvania Partnership, will discuss where the data gaps are, where old data is, how to keep it current. They will be charged with providing the Department of Health with their recommendations so that at the end of each year, we'll make changes to the report and publish an updated version. Marhawi, is there something else to say about that?
Nothing more to add. We plan to update it every January, and we are working on it. And of course, new topics will be added as we go on, and even the existing data sources will be updated, and we are working on this.
Great, thank you. Well, if there aren't any other questions, we can end the presentation up early. I definitely learned a lot, so thank you for your participation. The full recording will be posted on YouTube in the next few days, so if anyone missed the beginning, you can catch that there. Yeah, thank you so much to everyone who presented.
Thank you.
Thank you.
Thanks. Have a good afternoon, everyone.